We can start.
Okay.
Sure, we can.
Wait, YouTube is still showing that 1 minute is left.
It's 2 minutes more, 28 now.
Yes, we are live. Check now.
Oh my god, it's still showing 1 minute, 26 seconds left. We'll start only at
Refresh it.
12:30 there.
Refresh it because Iris PG is showing that they have started.
There might be time lag.
Ask them to reload the page.
Ma'am, do you want to switch on your camera or is this fine?
My camera.
Yeah.
Oh, I can't see any. Switch on the camera. You know how to switch on. What do I do now? Oh, start video. Huh?
Yeah.
Okay.
Yeah, now
Yeah.
we can see you also.
Okay. Okay.
Hey, someone refresh the page in YouTube.
Yeah, I'm just give me 1 minute.
It says 15. Oh, it started now.
It's staying 44 seconds. It's still left.
Guys, please start. Okay. We are live. So I'll start now.
Yeah. Start.
Okay, fine. So on behalf of IMA, we welcome all for the What to Do workshop by IMA MSN Tamil Nadu. Medinfinite 2020 is an online medical conference conducted by the IMA MSN and JDN Tamil Nadu for the medical students and doctors from July 16 till September 15. Mastering the cognitive knowledge within a field such as emergency medicine is a formidable task. It is even more difficult to draw on that knowledge, procure, and filter through the clinical and laboratory data, develop a differential diagnosis, and finally to form a rational treatment plan. IMA MSN welcomes all Medicos with the courage to run towards the problem where death remains challenged and defeated in front of the emergency situations. Where medical knowledge is approached in matter of seconds, we welcome all the bold knights to adorn their shining PPEs and clad their stethoscopes for a fun-filled, disastrous scenarios in medicine and restore hope through this workshop. Learn to identify the emergency cases where symptoms may be hidden but won't miss the daring vision of a doctor. Let's learn and get inspired for a wonderful presentation by one of our best speakers, Dr. G. Shreedevi, MD in Accident and Emergency Medicine, Sri Ramathandra Medical College and Research Institute. Ma'am, please take over.
Yeah. Hello. Good afternoon, everyone. So we're going to talk on common emergencies. I'm not going to talk like what is MI, what is the history, what is the complications, all that. I'm just going to practically deal with how do you deal with the cases. If a patient comes with MI or chest pain, how do you deal with, how do you come to the diagnosis? That's what I'm going to talk on. This is more of practical knowledge rather than a theoretical knowledge. Okay, thank you. We'll start now. Okay, so old man coming to the emergency department with a history of severe chest pain and a sweating. So what do you think of first? Any patient coming to the emergency, the first thing you are supposed to do is triage the patient. What do you mean by triage? Triage is nothing but sorting of patients. When a patient is having chest pain, okay, you're going to ask a small history, short history. Okay, what is the chest pain? Where is the chest pain? And how severe is the chest pain? And then, of course, you're going to check the vitals like blood pressure, heart rate, and saturation, which is important, very much important nowadays. And then, of course, the captured blood glucose for all the patients coming to the emergency. That's what we do in our SRMC. And okay, then what is it? What is the next thing? You receive the patient in the medical bay. Okay, then what else? What else you will think of? Say all the chest pains are not MIs, and all the MIs are not having will not have a chest pain. The patient can come with abdominal pain, shoulder pain, or any pain, but still they can have an MI. You should not miss out an MI. Okay, so what are the differential diagnoses you can think of when a patient comes with chest pain? So the first important is you have to rule out MI. Don't think, okay, patient is having gastric pain, which, okay, it should be just a gastritis, and give some pan or gelusil and then just send them away. Okay, so like you should never miss. I'll tell you a scenario what happened. One 30-year-old boy, guy, has gone to a hospital, okay, with a gastric pain. Okay, so the hospital, there was no doctor there, and because it's a very small hospital, the nurse was there. Okay, he looks like a gastritis. You just have gelusil syrup, you'll be fine. Okay, the same patient was brought to the emergency department of SRMC, but brought dead. Okay, so there was a slip where the patient has gone to a small hospital and they've given just a Gelusil or pan or something and they've sent it to him. But if they would have taken an ECG, they would have not missed the MI. Even if they can't do anything, they could have sent the patient to a tertiary care hospital rather than just giving pan or something like that. Okay, so the most commonest cases we see with a chest pain is MI, and the next is the pneumothorax. Okay, of course, gastritis will come. If you cannot miss one patient of MI, but you can miss gastritis. That's okay, but you should not miss a MI or a pneumothorax, which will end up with a death actually. Okay. Okay, what is the immediate action? The options I've given is Gelusil syrup 3 spoons, injection pantoprazole 40 mg IV stat, rest and sorbitrate under the tongue, maybe the muscle spasm. So what they do, okay, the chest pain is there, I'll put some diclofenac ointment, you will be okay. Okay, that's what some people do. So all that is not necessary. What is your action is? Okay. So action is rest and sorbitrate under the tongue. So assure the patient, okay, you have an MI, anything can happen. Don't tell the patient like that. Okay, so tell them nothing is there. You are okay. You reassure the patient first, which is very, very important. And then we'll give medicines. It'll be okay. You'll be fine soon. So the talking is very, 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 very important on a ER setup. So what is an MI is nothing but there will be decrease in oxygen. The oxygen and nutrients in the blood is not sufficient. It's not sufficient for the demands of the heart. So that's why the muscle of the heart aches. So that's why the patient presents with chest pain. So what do you mean by point of care testing? Point of care testing is nothing but the test which you do on the bedside is called as point of care testing. So like ECG, cardiac, whatever test, cardiac enzymes, chest X-ray, what are the tests we do? And then what else we do? Echo we do, and then ultrasound we do in a point of care testing. These are all the point of care testing. So for this patient, what is important now? ECG is important. Okay, that will take not more than 5 to 10 minutes. Okay, so you're taking ECG, and then cardiac enzymes. Mainly, what are the cardiac enzymes? Troponin I, BNP. These are the important cardiac enzymes, which will take around 20 minutes to half an hour for the results to come. Chest X-ray maybe half an hour. Echo also will be within half an hour. So when you take an ECG, so what do you see? So this is a normal ECG. I'm showing this. So this is a normal P. So there are about 12 leads here. Okay, lead 1, 2, 3, AVR, AVL, AVF, V1 to V6. So these 6 are limb leads, and these 6 are precordial leads. That is, you are keeping the leads over the precordium. So that's called as, this is why it's called as precordial leads. Okay, these are called the limb leads. So you see every lead, you see a P, QRS and a T wave. Okay, this is a P, this is a QRS and a T wave, right? Okay. So this is normal ECG. When you call the patient is having a ST elevation MI, see, this is the J point. This is the J point. So if you can see here, this is the P, this is the Q, this is the R, and this is S, and this is the T wave. So I don't want to go in what is P wave, what is QRS, what is T wave. I think most of them will know. Okay. So what is important here is this is the J point. Okay. Can you see? This point is a J point. If this is the isoelectric line. If this J point is elevated more than 1 millimeter, okay. So you see 5 small squares are there here. So this is 1 millimeter. One small square is 1 millimeter. 2, 3, 4, 5. So this is 5 millimeters. So if there is a rise of J point more than 1 millimeter, then it is significant. See, can you see this? The J point is slightly elevated, and slowly it is elevated like this. That means there is a ST elevation. That means the patient is having a MI. Depends upon whichever lead it is. Okay, so this is a ECG change where the patient is having a chest pain, and you see the ST elevation. Can you see here? Yes, this is the ST elevation. The J point is slightly elevated, and here you can see the elevation. So this is actually inferior wall MI. You don't have to know, okay, it's an inferior, at your stage, you don't have to know whether it's inferior wall MI or anterior MI or a posterior wall MI. It's okay. But you should know it's an MI. That is very important. You just can't see some of your friends can show this is my auntie's ECG which we took today morning. I don't know what is this ECG. Can you please explain what it is? Is it really emergency? Should I take him to a hospital immediately, or can I wait? Okay, you see the ECG, you don't know anything. Okay, I don't think it's nothing is a problem with ECG. I think you can go ahead and take some in pan or something, and he'll be fine. Don't do that. Okay, if you don't know, tell them you don't know. But at, when you are in third year or final year, you can't expect they will laugh at us, isn't it? So you are in final year and you don't know what is the ECG. So at least you should know to find out it's normal or abnormal. So the previous ECG is normal. This is the normal ECG, and this is the abnormal ECG. The abnormal, okay, there's some abnormality in the ECG. Please go and meet the cardiologist or a medicine people, something like that you have to tell. Okay, for that at least you should know some basics. So you see, there is ST elevation, lead 2, lead 3, and AVF. This is actually inferior wall MI. And of course, there is a ST depression also. Can you see the J point is come down? Okay, and TV, you can see the TV version here. So this is a posterior wall MI, because there's something called as ST elevation MI, non-ST elevation MI. So you can tell this is ST elevation MI and this is a non-ST elevation MI. So forget about all this. Just it's a normal ECG, abnormal. This is abnormal ECG where you can see the ST elevation. So then you can confirm it's a MI. That's it. That's what you have to know at this stage. Okay, what are things you are supposed to do if you are a CRRI or something like that, or you're working as a medical officer? What you should know? Okay, first is reassure the patient and do not overcrowd and make him get more anxiety. Okay, you have to start an IV line. Any patient coming to the emergency department, always think the patient can collapse anytime, and you have to be on your toes. So that's how you are supposed to work on. Okay. So start IV line as early as possible and take a ECG. And of course, though it's MONA is written, morphine is not the first thing you are supposed to give. Okay, the first is always A, B, and C. Okay, C, oxygen. You have to give oxygen, and then you have to give sublingual nitrate, and of course the aspirin, clopidogrel, atorvastatin. These are the drugs you're supposed to give. Just forget about all these numbers. You don't remember the numbers now. That's okay. We can check it later. Okay, so first is oxygen, then you can give sublingual nitrate, and if the patient is having a severe pain, they can go for morphine. Okay, they can go for morphine if the patient is having a severe chest pain. And again, it depends upon each person whether they are willing for interventions or they're willing for only for thrombolytic therapy. All that depends upon the patient also, because everything is money also. Okay, so PCI is a percutaneous interventions. Coming to fibrolytics. So fibrolytics, you all know it breaks the fibrin. So any clot, it will dilute the clots. So first is commonly used is streptokinase. And there are other things like altiplase, retiplase, all that. But streptokinase is why it's commonly used is cheap. So the person who is not willing to spend so much for interventions, they can start with streptokinase. Okay, I will use only this drug which is hardly around less than 5,000 maybe. So I'll use only this drug and I will get admitted. That's what they tell. I don't want any intervention because it costs some for him. So altiplase, again, one drug which is a bit expensive than streptokinase. Streptokinase will take at least 45 minutes to 1 hour to go on, whereas altiplase it's just take maybe few minutes. Okay, so that is the first scenario. Coming to the second scenario. So you are attending a marriage where you see a person who's collapsed and throwing seizures. Okay, what is your immediate action? So as you have seen in so many movies, give keys, then what? They will hold the hand and legs so that he will stop seizuring. So all that is wrong. So the options given are you can have some people will give iron keys to him. If you can, some people will hold the hands and limbs so that he will not, they will not allow him to seize. And there is something called as IV lorazepam and which we'll talk about it. Okay, so please not give any iron keys or don't control his limbs. That is not necessary. Usually any seizure will stop, mostly 75 to 90%, I think it will stop on its own within few minutes. Okay, you don't have to do anything. What you have to supposed to do is just turn the patient to a left lateral position. He has attended the marriage, so he would have had a very full stomach. So if you put the patient in left lateral position, even if he's going to vomit, all the vomit is going to come out. He will not aspirate. That's one reason. The other reason is when you are lying on a supine position, if you are unconscious, your tongue will be a foreign body, which will obstruct your airway, which will obstruct the patient's airway. So that's one of the reasons you put the patient in a. So these are mainly two reasons to put the patient in a left lateral position. So this is the left lateral position. That's otherwise called as recovery position. So if the patient is in ER, of course, you're not going to give keys or control the limbs or all. Okay. So you are going to take care of the airway, put the patient in the left lateral position, give IV lorazepam. Okay. These are two things we are doing in the ER immediately, as early as possible. So right action is you have to assure safety for the attenders, turn his head towards one side to prevent aspiration, and remove the hard and sharp materials near him. And you can give IV lorazepam as early as possible. So what you should not do is, as I told, don't give any iron things or don't control the movements. Don't insert anything in the mouth. So when it's seizuring, especially, to prevent the tongue bite, what you will do is you put your finger in the patient's mouth. So don't do that. So it will be your finger will be a foreign body for the victim. So do not insert anything forcibly in the airway, and of course, do not overcrowd. So coming to the third scenario, which is rarely seen because we are in the city. So you are working in a PHC where you receive a farmer, okay, with a history of snake bite 30 minutes ago. So what do? You have seen in movies, they will cut and suck, all that is there. Okay, they cut and suck the wound and they tie the tourniquet, which is your immediate action. They tie a tourniquet tightly above the site of the bite, tie a tourniquet above the site of the bite in such a way that it allows only one finger. Try native medicines. You have seen in movies, they would grind all these some green leaves, which is native medicines, and apply on the wound. Please don't do that. Place ice. Some people will place ice on the wound. Okay, so that it reduces the pain, and because it numbs the area and reduces the pain. That's what they think, but that's also not right. So the correct response is calm and reassure the patient. Okay, always when you have a snake bite, what you'll think? Okay, I'm going to die soon. So that's what your thought will be. So first, just calm the patient and reassure that nothing will happen. And you tie a tourniquet above the site where it allows one finger or one scale. This is to prevent from gangrene, because you are in a very remote place. To shift to a tertiary care hospital to take 1 hour or 2 hours, you don't know. So when you are tying it very tightly, what happens? The blood supply to the distal part will slowly reduce, and it will stop, and it can go for gangrene. That's the reason you are going to tie it tight, but allow at least one finger to enter in between. Okay, do not give anything by mouth. Why you are not supposed to give anything by mouth is, say for example, if the patient becomes drowsy, what happens? He's going to collapse, or if he collapses. So what happens? Whatever he's eating that time, he might aspirate. He might vomit and aspirate. That's why you're not supposed to give anything by mouth. Do not allow him to walk. So say there's a snake, but usually it will be in the leg. So always immobilize the leg. Do not allow him to walk, because the more the walking, the more the blood supply will be circulating the whole body. So it's going to be dangerous for the person. So that's why don't allow him to walk. Immobilize the limb and inform the ambulance as early as possible and shift him to a tertiary care hospital. So okay, coming to classification. You don't worry about this LRPD, YPD, all that. Okay, remember this: neurotoxic, hematotoxic, and myotoxic. Neurotoxic is all CNS symptoms. Hematotoxic is neurotoxic is caused by cobra and crate, like ptosis, all the CNS symptoms. Hematotoxic, remember it as viper as vascular, so you won't forget. Okay, so it is hematotoxic by viper. And then myotoxic by sea snakes, like the patient can present with hematuria, there's myoglobin urine, they can go for compartment syndrome with the bite site. So just remember it as neurotoxic by cobra arcade, hematotoxic by viper or viper vascular, and myotoxic sea snakes. Okay, how do you differentiate whether it's a venomous or non-venomous? You can't sit next to the snake and see, oh, this is round and this is triangular. Oh, this has a fangs and this has a the elliptical pupil? Definitely not. Some very rarely, some people, like when you bring the victim, like a snake bite victim, they bring the snake also. They'll hit the snake and bring the snake also. At that time, you should know whether it's a poisonous or non. Mostly it will be non-poisonous, but sometimes poisonous snakes they bring. Okay, so at that time you should be able to differentiate between the venomous and the non-venomous snake. So venomous snake is usually just triangular shaped, and the fangs will be there, and you'll see a elliptical pupil. Whereas non-venomous, the shape of the head will be rounded, and the pupils will be round, and there won't be any fang marks. So this is how you differentiate between a venomous and a non-venomous snake. Okay, symptoms. The patient can, with a history of snake bite, the patient can come with any of the symptoms, or sometimes with no symptoms at all. The patient will tell, just I had a snake bite half an hour before. Okay, but patient will be absolutely conscious, oriented. He'll be like a normal person. It doesn't mean that he will not get any symptoms. So may or may not, but you have to be always careful. So you have to start an IV line always before you get the symptoms. Don't do everything after the patient gets the symptoms. The patient can get symptoms like dyspnea, dysphonia, dysarthria, diplopia, dysphagia. What is dyspnea? Dyspnea, you all know, that is the difficulty in breathing. Dysphonia is phonation. The patient will not be able to phonate. Okay, that is dysphonia. Dysarthria is arthria. Articulation. Arthria is articulation. They will not be able to articulate the sentences. Diplopia is, there is a double vision. Diplopia is double vision. Dysphagia is difficult. Phagia means swallowing. Dysphagia means difficulty in swallowing. These are the 5 Ds, just to remember. And then ptosis. Ptosis is the patient will not be able to open his eyes. There will be ptosis, and there will be complete paralysis also. So these are the symptoms and signs you are supposed to look for in a snake bite. Okay. So usually, what is bedside LFT? LFT is lung function test. You can hold your breath and normally count for how long? Usually it will be more than 20 counts. Okay, if the patient cannot count more than 20 in a single breath, okay, then that means you have to suspect there's a snake bite. That's one. Second is breath holding time. You can hold a breath even for 1 minute. Okay, so at least more than 45 seconds. If the patient cannot hold the breath for 45 seconds, that means you have to suspect a snake bite. So when you ask for the history to the patient, if he is able to complete a sentence in a breath, that means he's fine. Okay, if he is not able to complete a sentence in a breath, then again he's at risk. So there's something called as 20-minute whole blood clotting time. So what you do is you take a blood, okay, and leave it for at least 20 minutes. If the blood does not clot, that means there is no, at that point of time, there is no envenomation of the snake bite. If it is positive, that means if the blood can move, that means it's a positive result. That means there's a snake bite. So this is called as 20-minute whole blood clotting time. So these are very important: single breath count, breath holding time, which is not more than 45 seconds, and single breath count will not normally be 20 counts, and he'll be able to talk usually, but in snake bite he will not be able to complete a sentence, and there will be 20-minute whole blood clotting time. Will not clot. The blood will not clot in 20 minutes. Usually it will clot within 5 to 8 minutes. So what is the management for a snake bite? So it is anti-snake venom. Or the patient is very sick, go for mechanical ventilation. So these are the 2 things you are supposed to do. Okay, first is anti-snake venom and mechanical ventilation. So coming to the 4th scenario, so old person who's known hypertensive has come with sudden history of breathlessness, and his blood pressure is shootingly high, and his heart rate is high, his respiratory rate is high. So there's tachycardia is there, tachypnea is there, and hypertensive. His blood pressure is very high, and if you auscultate, he's having bilateral crepitations. He's spitting the pink frothy sputum. So what do you suspect with all this? It is a pulmonary edema. Okay. So what are the causes? The causes already seen. He's a hypertensive. So mostly this is a hypertensive pulmonary edema. So of course, what is the cause for this heart failure. It's always not the heart. It's not only the heart failure. What is the cause for it? You should know. It could be anemia causing heart failure. It could be renal failure causing the pulmonary edema. It could be infected endocarditis or some drugs like antipsychotics. Some of the drugs, NSAIDs, can cause heart failure. So the patient, as you see, patient had tachycardia, patient had tachypnea, breathlessness, sweating. What are the hypoxic features? Along with this, the patient can have a decrease in level of consciousness also. That's an important sign of hypoxic feature. It's an important sign. And there'll be bilateral basal crepitations. So how do you diagnose heart failure? As I told you before, in the case of MI, you should do cardiac enzymes. In the cardiac enzymes, there was troponin I, BNP was there. So if the BNP is really high, this is a point of care testing. It will come immediately within 20 minutes. If the BNP is high, it's more of cardiac problem. If the blood test you do is the diagnostic criteria for heart failure is the NT-proBNP, N-terminal pro beta natriuretic peptide. So if this is more than 900 picograms per ml, it is diagnostic that the patient is having a heart failure. What is negative predictive value? The negative predictive value means if the pro-BNP is less than 500 or it's normal, that means the patient is not having a heart failure. It has a very high negative predictive value for heart failure. So how do you treat this patient? First is because the patient will not be able to lie down flat. So ask the patient to sit straight and give him oxygen, which is needed at that time, and give furosemide. Furosemide, or it's called as Lasix. Furosemide, you have to give 1 mg per kg or incremental dose, 100, 100 plus 100. Maximum you can give is 360 mg. So this is a furosemide. What is furosemide? It is a diuretic. Okay. So next is injection morphine, again in incremental doses. It is maximum you can give us 10 mg. So it is again 0.1 mg per kg. So you can give injection morphine. It also decreases the preload. So the next coming is vasodilator. Vasodilator, you use it for to decrease the blood pressure. Maybe what we start here in SRMC is, we'll start NTG around 5 to 25 milligram per minute infusion. We usually start with an infusion. We don't give bolus usually. We start with an infusion, especially if old people, we don't want to reduce the blood pressure drastically. So slowly we'll reduce the blood pressure. So the treatment important is, first is make the patient sit straight, oxygen by any means. It depends upon each patient. You can keep NRBM or a non-invasive ventilation where if you give 100% high flow oxygen. So that's an NIV. Or you can start with morphine or furosemide, everything. And then, of course, you have to start with a vasodilator to decrease the blood pressure. Okay, so we are coming to the fifth scenario. A child, 5-year-old child, is brought to the emergency with a history of respiratory distress, who's a non-asthmatic. So what do you suspect is, he is a non-asthmatic. There should be bilateral V's for the patient. So the important is, of course, every time all the patients I have told you is, you have to triage, you have to do, I don't have to tell for each and every scenario, you have to triage the patient, all the vitals are important, start IV line, take care of the A, B, C, that is the airway, breathing and circulation. This is all important. I don't want to repeat this again and again. Okay. So the investigations is, you have already started a line, you have taken an ABG. So, and you have to take a chest X-ray. The important complication for asthma is a pneumothorax. You should not miss that. So that's why we usually do a chest X-ray to find out any other complications along with the other than the normal chest, anything abnormal in the child. So ABG and chest X-ray is important for asthmatic patients. So how do you treat this patient? Of course, you make the child in a sitting position, give oxygen according to the patient. Like if it's severe V's or something, you start on nebulization. Otherwise, they can have their own inhalers. Of course, if you have not started IV line, you have to start IV line. You can start with ipratropium and salbutamol nebulization, which will ipratropium will dries up the secretion. Salbutamol will dilate the bronchus. So there will be it will dilate the bronchus so that the child can breathe properly. Okay, so these are the bronchodilators we are supposed to use. So when you will intubate, when you will think that you have to intubate the child, you take an ABG. What all you see in the ABG is, you first see the pH, PCO2, PO2, saturation. Depends upon each case. Renal failure, you see different things like pH you see, PCO2 you see, bicarb you see for a renal failure patient. So each patient is different. So depends upon the patient condition, you see the ABG. So these patients you see a pH, PCO2. So if there is an increasing PCO2 and a decreasing sensorium of the child, you have to think of intubation, plan for intubation, and intubate the child. Now, COPD and asthma is almost the same, but a slight difference will be there. So usually in a COPD, what they tell is to not give oxygen because their blood is always high, CO2 will be there. So normal CO2 is 35 to 45. So usually they'll have 50 or 60 depend upon the how many years they're having the COPD. So they are used to the CO2, don't give high flow oxygen and decrease the CO2. That's what they say. But in emergency, if the patient is coming with unconsciousness and is cyanosed, don't wait for to give 2 liters of O2, 4 liters of O2. Give treat the patient with 100 liters of O2, and if it's if the patient is really unconscious, is not obeying your commands, plan for intubation. That's the important thing you're supposed to do. Don't give 2 liters of oxygen just because he's a COPD. Again, the investigations is you have to take an ABG. Again, if the you have to look for the PO2. If the patient can die of hypoxia rather than hypercarbia, so you have to do a ABG, look for the PO2, PCO2, chest X-ray, and the bloods, normal blood, CBC, RFT, replace all that. And the treatment options is, don't give any oxygen because someone will tell, okay, no, don't give any oxygen because it's a non-COPD patient. No. Oxygen 2 to 4 liters? No. Oxygen by non-rebreathing mask? No. Patient, the best line of treatment is intubation with 100% oxygen. Because as I told you, hypoxia will kill the patient rather than hypercarbia. Don't hesitate to give 100% oxygen in a hypoxic COPD patient. Very, very important. Okay, do not stop the oxygen for the COPD patient. Coming to the scenario which we usually see, the non-diabetic patient found in an unconscious state or a confused state. Okay, so what we do is we do everything. We do blood pressure, we check heart rate, we take ECG, we'll do everything. But if we forget to do at that time, unconscious, we'll also be tensed. So what happens when we received a patient, okay, a history of similar history, and they have been taken to a hospital where the patient was intubated. They have done everything, but still the patient is not conscious. Okay, when we received the patient with in an intubated state, and when we took a CBG, it was low. So the simple reason is only hypoglycemia. If they would have checked the CBG, okay, and then given the dextrose, the patient would have survived. We would have avoided all this intubation, all this problems just by giving sugar. So it's hypoglycemia. Okay, so always ABC. CBG is a must for all the patients, not only emergencies, all the patients entering into the emergency. You have to do a CBG. It's like one of the vital signs. Like when you check for the vital sign in the triage itself, you have to do a CBG. Okay, so give 25%. We have, for this patient, we gave 25% dextrose infusion. Infusion. And then the patient slowly started coming out. Of course, we can't extubate such patients immediately. We have to wait for some time and then extubate. If it's at home, you can give sugar crystals. If the patient is becoming drowsy or something, as a non-diabetic, especially elderly people, you can give sugar crystals at home. Do not give anything orally when the patient is unconscious. Don't give chocolate or don't give juice or anything when the patient is unconscious. Any unconscious patient, avoid anything orally because it can aspirate and it can the patient can go for a worse situation. Okay, so now coming to the old female was brought to the emergency with a history of right side body weakness. It's today morning 7 a.m. They brought the patient by 8 o'clock. Within an hour's time, they got the patient. So what do you want to do? What is your immediate line of treatment? So you think it's a stroke. Okay. So before that, okay, patient is having weakness. There could be some differential diagnosis also. Okay. the patient is having 1 hour of weakness. Okay, what all you can think? One is stroke. Okay, the one is hypoglycemia. Always you have to check for the CVG. Sometimes the patient hypoglycemic also they can present with stroke. Weakness, and then some people they present with only lower limb weakness. This is one of the reasons is hypokalemia, hypokalemic periodic paralysis. Even the younger patients, 20 or 25 years, they come with lower limb weakness. So when you check the potassium will be less than 2 or 2.5, very less. So when you give potassium, they will absolutely come back to the normal within 2 hours. Okay, so it's really a miracle, especially this hypokalemic periodic paralysis. If you think that okay, this is a stroke and you do something else and leaving this potassium, then it's gone. Okay, so always you have to suspect any patient with a differential diagnosis, not just one diagnosis, and then you can come back. You can with the history, with other things, you can come to a diagnosis. So now we are talking about the stroke. So what is stroke? It's like a brain attack. It's like a heart attack. We are going to tell it as it's actually a brain attack. So every minute matters. Like an MI, it's equal. The MI and stroke are almost the same. Okay, it's every minute matters. But usually the stroke patients who are coming to the emergency department will usually come late. They'll come the next day or within 6 hours or within 7 hours. Very rarely they come within 4.5 hours. So as you all know, the brain does not have the facility to store glucose. So they'll run out of the glucose when there is a decrease in blood supply to the brain. So how do you confirm stroke? As I told you, you have to do a CT scan or a MRI. CT scan is mainly to diagnose the patient is not having a hemorrhagic stroke, because hemorrhagic stroke, you're not supposed to thrombolize the patient. So that's a different field. The neurosurgeons will take care of it. Okay, so that's why you take a CT scan to know whether there is no hemorrhagic stroke. So how can you remember it as symptoms and signs? You remember as be fast, balance. The patient lose the balance, okay, and the eyes will be blurred vision, or sometimes the patient cannot close their eyes tightly. That's one. And face, there'll be one side of the face will be drooping, so they cannot close eyes properly. The one side of there'll be drooling of the saliva on the one side, and when you compare when it comes to the arms will be drifting towards one side. On speech, they cannot there'll be disarticulation. They cannot pronounce, or there'll be slurring of speech. That's what slurring of speech will be there. Of course, if you see all this, immediately call for ambulance and immediately shift the patient to a tertiary care hospital. So there's something called as TIA. TIA is nothing but transient ischemic attack. So transient ischemic attack, they are usually what they have an elderly patient who's having weakness, say for an hour, and then he'll become normal. So what he usually thinks is, okay, I'm fine now. Maybe something happened. That's why I had weakness. So he eats something, okay, after eating, I'm fine, and then they just forget about. So these are the patients who come with MI and stroke later on, but they will not give a history of TIA at all to you. But what is TIA is, the patient will have neurological dysfunction, okay, for at least less than an hour. Then they will not have any evidence of infarction after 1 hour. Everything, all the symptoms, everything will recover. They will recover within after 1 hour. So there are actually huge risk of MI and stroke, which they are supposed to give dual antiplatelets, especially aspirin or clopidogrel. They have to give dual antiplatelets for further to avoid a stroke or. So when you classify stroke, 85% is ischemic stroke and only 15% of hemorrhagic stroke. But usually, as you see in the hospital, like we see more of a hemorrhagic stroke also as equal to the ischemic stroke. Practically, I'm talking more of a hemorrhagic stroke, because ischemic stroke, many people will not come to the especially tertiary care hospital. So that's the reason we see almost the same amount of ischemic and hemorrhagic stroke, though the paper says 85% is ischemic and 15% are hemorrhagic stroke. So you see, this is the hyperdense lesion. Usually this is the right side and this is the left side. First is that is you should know. This is right and this is left. Okay. This is the thalamic bleed. This is a hyperdense bleed, and this is the MCA infarct. Such a big infarct. There's a MCA infarct, and this is hypodense. This is a hyperdense and this is hypo. This is a CT brain. So if the patient comes within the 4.5 hours, you can thrombolyze those patients. If it's more than 4.5 hours, they have to go for interventions. So what are the thrombolyze? Usually we give in our hospital is altiplase. So the dose, you just forget about it. If the patient comes within 4.5 hours, it is a golden hour and you have to start the thrombolysis. If the patient goes beyond the timing, the patient will go for endovascular interventions, and the intervention people, the radiology intervention people will take care of the person. Now, coming to the patient is brought to the ER with history of tablet overdose 4 hours after the intake of the tablet. Okay, what do you do with this patient? Okay, if there is always patient is conscious, again you have to divide this patient to conscious, unconscious. So conscious is having a different treatment. Unconscious patients have a different treatment. All poison patients should be managed as if they're initially they might be okay, they'll be conscious oriented. So it doesn't mean that it's stable. Maybe at that point of time it could be stable. The patient can go collapse or can happen. Anything can happen anytime. So always be careful that this patient can have a life-threatening intoxication also. Okay, when a person is coming to was brought to you at around in the morning, say the attendants are telling the patient was unconscious in the morning. Okay, we don't know what happened in the night. So we have to think of so many things. Okay, maybe if the patient is had a binge of alcohol. Okay, so what you first is you have to check for the glucose. Very, very important. So this patient can go for hypoglycemia and then they'll be just lying. So always first is check CBG level. CBG, if it's normal, give 100% oxygen. Of course, airway you have to take care. And then if there's any opioid poisoning, overdose or something, you can try one shot of naloxone 0.2 mg. Okay. Thiamine, if the history of alcohol or something is there, alcohol binge or something is there, you can give thiamine in 100 ml MS, and you can give all these things and try to see if the patient is coming out. Okay. The common antidotes for OPC. OPC is organophosphorus compound. Okay. The antidote is pyridoxine. For a paracetamol, it is N-acetylcysteine. For a beta blocker, you can give glucagon or insulin. For opioid, as I told you before, it is naloxone. Heparin. Heparinol is very, very, very rare. Opioid also is very rare, not common in our country. And the commonest is OPCD, paracetamol, and the next common is beta blockers. The others and all is very, very rare. Opioid, heparin, iron is very, very rare. So how do you diagnose? First is with history and circumferences, like circumstantial evidences, like I saw this tablet, which is empty tablet covers I saw there, or some injections. Some people, OPC, they take even IM injection also they take, or some people, they apply it over the body. So what you do is you have to, you will see, OPC means you will see the typical features like salivation, lacrimation, defecation, and the smell also. This is a typical feature of the smell of the OPC. You can tell it's okay, a patient is taking OPC. Okay, and then you put a rice tube wash. If the patient is conscious, you can put a rice tube and wash and take the sample for gastric analysis, and you can confirm what are the diagnosis later on. Okay, so management, always ABC, airway, breathing and circulation. If the patient is unconscious, you have to plan for intubation. When you intubate, if the GCS, what is GCS? Is Glasgow Coma Scale. There is if the GCS is less than 8, you have to always intubate. So normal GCS is 15/15. Okay, if the GCS is less than 8, you have to intubate. If there's a rapid deterioration of the GCS, also you have to intubate. Or there's a respiratory insufficiency, you have to intubate the patient. These are the 4 conditions where you have to plan for intubation. So if the patient is conscious, you can do a gastric lavage. If the patient is unconscious, you have to intubate the patient and then only you can do a gastric lavage. Otherwise, the patient will go for aspiration and he can collapse anytime. So you can give a charcoal lavage. The dose is 1 gram per kg, and stop further exposure. You have to actually, as soon as the patient comes, you remove all the clothes, wash the body, because you don't know whether he's applied or he has taken it, he has poured it on his body. We don't know. So remove all the dresses to avoid a further exposure, and then clean the body with a body wash or something like that. So Activated charcoal. What the activated charcoal does? It's absorption. That means it will bind with the drug. The activated charcoal will bind with the drug, and it'll avoid getting absorbed in the GI tract. So it gets eliminated along with the bowel movements. So the doses, as I told, it's 1 gram per kg. So the contraindications are if the patient is comatose, you can still give if there is unconscious patient through the Riles tube, But if avoid especially in intestinal obstruction, corrosives, or if it's already taken an oral antidote and it's hydrocarbons like petrol or kerosene, usually the children will come with kerosene poison. So for all these cases, it's better to avoid the activated charcoal. Now, coming to the 10th scenario, a young male who is brought to the usually is a dental clinic for tooth extraction. Okay, the patient developed hoarseness of the voice, breathlessness suddenly, and sweating and rashes, and was after giving local anesthetic. So as soon as you give a local anesthetic, the patient develop all these symptoms. So what do you do? So what do you think of is anaphylaxis? Clearly shows anaphylaxis, especially dental people. They'll get scared. They don't know what to do. Because they cannot start a line. They cannot. So it's always you have to suspect, especially such cases. It's really worrying. So in our hospital itself, they have brought 1 or 2 cases from the dental block to the ER with this anaphylaxis. So the patient can have breathlessness, angioedema, wheeze, hypotension, tachycardia. They can present with all this, and then the patient sometimes can become unconscious or can go for a cardiac arrest also. Okay. So treat with airway breathing circulation, give a full high flow oxygen, elevate the legs so that there'll be a flow of, the pressure of the blood will come to the heart, and then give at least 2 to 3 liters of IV fluids. There's mainly distributive shock. This is anaphylaxis. It's a kind of a distributive shock. So there is fluid in the body, but it's the distribution is the problem. So give lots of fluid to the patient and give injection adrenaline. So usually adrenaline is in one ampule. So in 1 ampule you will have 1 ml. That 1 ml is that you take 1 ml and you have to dilute and you have to give it. Okay. If it's an IV, you have to dilute and give it. Otherwise, you give 0.3 to 0.5 mg subcutaneous or IM you can give. If it's a severe life-threatening, you have to always think of giving IV. The cardiac arrest, it's ACLS protocol. You have to give 1 mg direct IV. The ACLS protocol is a completely different scenario. Just forget about this. For anaphylaxis, you have to give fluids, adrenaline. Start IV line, fluids, adrenaline. These 2 are the important things. So coming to the 11th scenario, patient present with severe breathlessness and profuse sweating. As you examine, you notice that there are no breath sounds on the right side, and trachea is pushed towards the left side, and respiratory rate is high, pulses are feeble. There is a high potential with that. BP is not maybe 90-60. So what is this? The diagnosis. You are thinking of severe asthma? No, because there is no wheeze. So okay, because there is no air entry in the right side, there is no wheeze. So there is no asthma, there is no COPD. It could be either a pneumothorax. So it's a tension pneumothorax. There's no history of trauma. So it is a tension pneumothorax. So what do you do for the patient? What happens here is, you see, this is a intrapleural space. So air gets collected here and push the lung towards the opposite side, towards the left side. So what it does is, it is pushing the mediastinum towards the opposite side. So this heart is pushed towards the other side and then get compressed. So when it gets compressed, what happens? The cardiac output also is reduced. The patient can go for hypotension. If you don't relieve this air immediately, the patient is going to arrest any time. So what you do is, you do whether you do a chest X-ray first, or you do ICD, or you do chest X-ray AP and lateral view, or needle thoracocentesis. So the first line of action for such a tension pneumothorax is, don't wait for anything. This is all a clinical diagnosis. There's no, it will take at least half an hour to arrange for an ICD. It will take at least half an hour to get an X-ray ready. But so what you have to immediately do is needle thoracocentesis is the first line of treatment. So how do you do needle thoracocentesis? You have to take a needle or an IV line. Okay, this is the mid-clavicular line. This is the second intercostal. This second intercostal space. This is the mid-clavicular line. In this, you're going to puncture with the needle, so to relieve the air from chest to outside atmosphere. So you sometimes if you connect it to the water bubble, with water the tube, if it gets connected to the water, you will hear the bubbles. So much of water will be, so much of air will be gushed into the water, and you can see the bubbling there. So that is pneumothorax. So that's what you're supposed to do. You have to do a thoracocentesis. Needle thoracocentesis is the line of treatment at that point of time. Later on, you can do ICD, all that, chest X-ray, all that you can do. But at that point of time, if you don't do that, if you wait for all these things, the patient can collapse anytime. So the first line of treatment is a needle thoracocentesis. Or elderly male comes to with history of choking while eating, and he feels uneasiness in his throat. What's your plan? So again, depends upon whether the patient is conscious or unconscious. If the patient is conscious, is able to breathe, or he is able to cough, encourage the person to cough. When you encourage the person to cough, what happens? There will be a intrathoracic pressure is increased, thereby pushes the foreign body outside. Encourage the person to cough till the person collapses, or give a Heimlich maneuver. You can go for Heimlich maneuver. So this is the universal choking sign. Okay, this is the Heimlich maneuver. You hold the patient like this. Okay, hold a fist in between the Ziphy sternum and the umbilicus, and you're going to push inwards and upwards. Thereby, you are increasing the intrathoracic pressure. Okay, you are going to increase the intra-abdominal pressure, thereby intrathoracic pressure, and the foreign body comes out. So you have to do ask the patient to cough. If he's not able to cough, you do a Heimlich. I mean, if he's not able to cough or breathe, you're going to do a Heimlich maneuver. If it's still, you do this Heimlich maneuver till the foreign body comes out, or till the person collapses. If the person collapses, you're going to start the CPR like what you do the basic life support. So coming to the last slide, what would you do if you find a person unconscious? Would you sprinkle some water as you watch some movies? Will they sprinkle water and give something orally, or tap him on his shoulders and try to wake him up? So the thing what you are supposed to do is tap him on his shoulders and try to wake him up. If he's not waking up, then it's a cardiac arrest scenario. Establish unresponsiveness. You're going to, after tapping him on his shoulders, if he's not waking up, okay, call for help. Check for the pulse or over the carotids. If there's no pulse, you're going to start CPR 30:2, which is the basic life support. I think you all know the basic life support. You have undergone this training in the first year itself. So I have finished. To save a life, you don't have to do great things, but you can do simple things in a great way. Okay. Thank you very much. I can take the questions if any.
Thank you, ma'am. You ended on a lovely note. And if any questions are there, please type them either in the chat box here or on the comment section on YouTube. We will be taking the questions now. Okay, ma'am, I'm starting the questions. The first question is,
okay,
is it a dictum to take an ECG for any chest pain case in a casualty?
Of course. Any chest pain, not only chest pain, any patient who's above 20 years. See, I'll tell you a scenario which has happened in our college. An 18-year-old, second year BDS. Okay, he had uneasiness he had a gastric pain. Right. So what he did is he went with his friends to the Archana. He told his friends that I didn't eat in the morning. That's why maybe I got gastritis. We'll go have a food, something to eat. So he was eating there. After he ate also, he still had pain over the gastric region. So the friends told, we'll go to the emergency. No, we'll wait for some time and see. So suddenly he collapsed. He collapsed in the Archana. So we were called from ER. So we took him and we brought him to the emergency where he had a ventricular tachycardia. So it's another cardiac arrest. rhythms. Okay, so we immediately shocked him, we revived him. So he's lucky that he was inside the campus. So I'm telling why I'm telling is even at 18 years when you can get an MI and when he can arrest. So I think you have to take for everyone who comes to the emergency department, it's a protocol to take a ECG. Even say a patient comes with a 60-year-old comes with history of maybe femur fracture. Okay, so you're going to do X-ray or POP, all that. That is only radio. I mean, only orthopedic problem, but still, I'm going to take an ECG for this old lady also. They can. It's not always only one. This is human body. It's not. You should have only one problem at a time. It's not like that. You can have two problems also at a time, right? So always it's better to take an ECG. It's safer to take an ECG at that time rather than if something happens later. Don't feel guilty later. Just to avoid your own guilty, it's better to take an ECG.
Okay, ma'am. Next question is, if the patient has COPD or other respiratory pathology and has come with a snake bite, do we wait for white blood cell count, or do we start empirical management?
No, you see, COPD, you have to airway, breathing, all will not wait for anything. You have to intubate, you have to unconscious, all, you have to intubate, you give 100% oxygen. Side by side, emergency is not only, one at a time. It is 1,000 things at a time. Okay, so because there are not only one person there. Okay, so one person will do one thing, the other person will do something else. Okay, it's not that you have to wait for and see the patient dying. No, it's not that. So you have to intubate, you have to do something. One person will start an IV line, will take blood and will do that thing. Okay, by the time you intubate, your whole blood clotting time will be going to be ready, isn't it?
Yes, ma'am. Next question. How can we treat scorpion sting since it may rarely cause pancreatitis?
Pancreatitis is not immediately. So as soon as a scorpion sting, you will not get pancreatitis immediately. It's a late complication. It's not an immediate complication. So pancreatitis, again, when the patient presents severe abdominal pain, they will not be able to sit or lie down, or you have to give, again, there will be a third phase loss. There will be so much of fluid loss. You have to give fluids and analgesics. You have to painkiller and fluid. This is the two things you have to give. There is otherwise there's nothing much. You have to control the pain and you have to give fluids. Pancreatitis, you cannot avoid pancreatitis. Okay, there's idiopathic cause of pancreatitis also. The main cause of pancreatitis is alcohol induced pancreatitis.
Okay, ma'am. Next question. What is the first line of management when a patient with very low oxygen saturation comes to the ER? Example, a COVID patient.
Okay, so the patient comes to the ER, everyone will be first careful. Okay, so there's something called as happy hypoxia at present. It's going on. So though the saturation is very low, say 60%, okay, in room air, so still the patient is happy sitting there. Okay, so what you do is you give you start with NIV oxygen. First is you have to give an NRBM, non-rebreathing mask oxygen, just to see if the patient's saturation is picking up. So if it does not pick up, you start with NIV or a prone ventilation. That's what they say now. Okay, prone ventilation is not supine; it's a prone ventilation. You give 100% oxygen with the patient, making the patient lie down in a prone position. Okay, you try that. Okay, if that also does not, then you have to intubate. There's no way.
Okay, ma'am.
And of course, you have to take a chest X-ray to see the ground glass appearance. COVID test should be done. All this has to be done side by side.
Okay, ma'am. Next question. In case of poisoning, while washing their body, what if the patient goes for hypothermia?
Yeah, you should not give ice water or something. Just a plain water. You should not pour ice water on the patient. Just a plain, like it's how you're taking bath. Okay, just clean it up. Just put normal water and cover him up. Don't just open it and keep it. Okay, just clean it and then wipe it and cover the patient. Cover the patient in a blanket.
Okay, ma'am.
Very rarely in India we go for hypothermia. We can go for hyperthermia, but not for hypothermia so easily. Especially in ICU patients, we can maybe, but not in the ER. I've not seen any hypothermic patients in ER.
Okay, ma'am. How to manage hepatic encephalopathy with seizures?
Seizures. Yeah. You immediately you have to give midazolam. No, I mean, so lorazepam. There is no other way to control the seizures at that point of time. So same like any other seizures. Don't think of hepatic and whatever the reason. Immediately how to control the seizures is important. It's like a COPD patient coming in unconsciousness. Oh, patient is having a COPD. I don't want to give oxygen. It's the same thing. Patient is having a hepatic encephalopathy. I should not give this. I should not leave the patient seizuring, isn't it?
Okay.
Okay. Next.
Next question is, ma'am, somebody is asking streptokinase causes anaphylaxis. So what do you do during myocardial infarction?
Yeah, what we do is we give adrenaline. Okay, we stop the drug at that point of time. Okay, we treat anaphylaxis, and then again we have to continue with the streptokinase. We try streptokinase, otherwise we have to stop.
Okay, ma'am.
You have to treat anaphylaxis. You stop the drug. Whatever drug you give, it's not only for streptokinase. For any drug or anything, you can have anaphylaxis. Even for groundness, they can have anaphylaxis. Stop the drug immediately. Okay. If it's very minimal anaphylaxis like itching or something, you give some Advil or something, and then you can try and restart the streptokinase. Okay. If still is having worse symptoms, you're going to stop streptokinase and go for some other treatment like take him for PCI interventions, something like that.
Okay. Next question. In case of anaphylactic shock, what can we do if EpiPen is not available?
Okay. So there's nothing you could do. You should give only epinephrine. There is no other drug. That is the only drug.
Okay.
There is no, see, a hospital, if you are taking the patient to a hospital, there's no adrenaline, means there's no, it's a you cannot tell that's a hospital. Understood? So there is no hospital without adrenaline.
Okay,
or you have to take him to immediately to a nearby hospital.
Okay. Next question. Somebody wants to know what they should do if somebody collapses in an airplane and cannot breathe.
They cannot breathe. Okay, so you can give as a first aid. Okay, as a.
They actually want to know if an emergency tracheostomy should be performed.
No. Don't. What is that Marcel movie? Don't do all that card cutting and all. Okay, it's very risky in the flights and all. You can't do all that. You can give mouth to mouth breathing. Okay, you can give. You can attach. There will be AED in the flights. You can attach the AED. You can give shock. It depends upon whatever the AED tells. Okay, so you can give mouth to mouth breathing. It's say the BLS. You have to finish the BLS. Don't do all this tracheostomy in the flights, and you're going to kill the patient. Something happens. Okay, so just do basic life support in a different atmosphere other than the hospital.
Okay, ma'am. Next question: what to do for kerosene poisoning? What is the antidote?
There is no antidote for kerosene poisoning. See, what happens when you pour a petrol or a kerosene on the floor? It evaporates. Okay, so the important thing is you have to look for. Usually, the child will not take more than unless intentionally the child will not take more than 5 ml because the taste is different. Maybe by mistake the child would have taken, or if an adult takes about 500 ml or 200 ml of kerosene, he has to be admitted. He has to. We have to do a chest X-ray or something like that. Okay, so this will cause pneumonitis or inflammation of the lungs. Nothing at that time. You should not do put trials tube and wash. These are the hydrocarbons. You're not supposed to give a lavage for hydrocarbons. It will evaporate on its own.
Okay. Next question. If a patient has a cut at the wrist as suicidal tendency.
Sorry, what cut at wrist?
Yeah, as suicidal tendency, what to do first? If somebody's cut their wrist.
Oh, okay. Just give pressure. Just give a good pressure, okay? At least for 10 to 15 minutes. Cut the wrist. Okay, you give a good pressure, okay, because maybe some tendon rupture or something, they cut the tendon or cut the radial artery, whatever it is. You give a good pressure, good tie it up, and then shift him immediately to the hospital.
Okay, what about a case of drowning?
Drowning. Okay, so drowning is usually they'll be very cold as soon as you bring the patient out of the water. Okay, so warm them up. Okay, if there's no pulse or something, start CPR. This is the same thing as BLS. You start the BLS, but one thing is you have to warm them up. They take a longer time to come back. So that's why the prolonged basic life support is important in case of drowning. If you are, say, for example, if you are doing CPR for half an hour or 40 minutes in a normal individual, you have to do more than 1 hour for a drowning patient.
Okay, ma'am.
You have to cover them up. First is important, warm them up.
Okay, ma'am. Management of heat stroke, opposite.
Heat stroke. First is usually it will be more than 102, 103. I have seen till 108. Okay. So first is remove all the dress. Okay. Give him good sponge bath. Sponge bath is you put a normal saline. Don't put ice water or anything. Give a normal saline. There's no point in giving paracetamol for these patients. Okay, because the thermoregulatory center is switched off for these patients. Okay. So you keep a fan nearby, give IV fluids, IV saline, nasal, intranasally you can give a bladder, wash, abdominal wash, bladder wash you can give, start IV and give fluids. Okay, you have to, the aim is to reduce the temperature. That's what you're going to do. So put a blanket over the patient and with a wet blanket. Put a wet blanket over the patient and with a fan nearby so that it the body gets cooled up.
Okay, ma'am. Next question. A conscious patient with COPD comes with SpO2 79%. Should we intubate him?
No. Why you want to intubate? As I told you before, any GCS, the GCS, normal GCS 15. Okay. If the GCS is reduced less than 8, or if there is a deteriorating GCS from 15, okay, then you plan for intubation. Why for saturation less than 70, you don't have to intubate. You give oxygen and see first. Okay, whether it's improving or not, you take an ABG and slowly you have time to do step-by-step work. You directly don't intubate everyone.
Okay, ma'am. Next question. Is precordial thumb validated in witnessed cardiac arrest?
No. There's the precordial thumb has been taken out long time ago.
Okay, ma'am. In case of seizure patient, if the patient bites the tongue, what to do?
Nothing can be done. Just leave it. It'll automatically heal by itself.
Okay. I'd just like to tell everybody before I go on to the next question that in the next 5 minutes, we have to end the session. So I will take as many questions as I can till then. After that, we will conclude the session. The next question is, a person suddenly becomes unconscious, no history of diabetes.
Okay.
BP, is it safe to give patients salt/sugar water as in common household practices? And how to identify if patient has gone for low BP or high BP?
Okay, as I told you before, if the patient is unconscious, nothing by oral should be given. Okay, you don't give anything orally. You shift the patient as early as possible to a nearby hospital. Don't you should not any BP. How will you check BP? Whether it's a high BP or low BP, you're not going to do anything at home. So shift the patient as early as possible to the hospital. Don't give anything by mouth, even if it's hypoglycemia. Also, call the ambulance. They'll come. They will maybe the paramedic can give IV dextrose if there is hypoglycemia.
Okay, ma'am. Next question. What happens if a known hemophilia A patient comes with severe head trauma?
Okay, so we have to arrange blood for these patients. Usually they need blood. Okay, start IV line. Okay, arrange for blood. Okay, so give blood. That's it.
Okay, ma'am. And what is the immediate measure you have to take in case of electric shock?
Okay, electric shock, you have to be very careful because it's the outside atmosphere is different from the inside atmosphere. That means the body might look normal to you, but there'll be so much of problems inside the body. So that means later on it'll come out. So because electric shock usually have a entry wound and exit wound. So you have to see, because where the shock enters the body is the entry wound, where the shock leaves the body, like into the earth, is the exit wound. Okay, you can see the entry and exit wound. It usually crosses through the heart, so it can cause problems in the heart. It can cause arrhythmias like VT, VF, always start and there will be so much of fluid loss in this. So start IV line, it's like a burns patient. Okay, so start IV line, give fluids according to the how much of the burns externally, and also look for the vitals or all BP, how is the BP, everything, and then give fluids. And you have to take an ECG also for these patients. So I mean, any ECG changes at that point of time, and usually these patients will be thrown out from the from the electrical point site. So if they are thrown out, you have to look for any trauma like head injury or neck injury or any other injuries to make sure that there is no orthopedic problem for the patient.
Okay, ma'am. 2 questions more I'm going to be taking. What to do in road traffic accident head injury to stop bleeding on spot if the patient is unconscious?
Any bleeding anywhere, say it's wrist or head or wherever it is, you give a good compression. That's very, very important for that at that point. You can't do more than that in that situation. So you give a good compression for at least 15 to 20 minutes and then shift him to a safer place. Wherever is the bleeding, no problem, give compression.
Okay, ma'am. Last question. You've answered this before, but that time we hadn't started. What is the scope of emergency medicine in India and abroad? Like which colleges offer courses and what other future perspectives are there?
So there is, I mean, recently, I think for past 5 years, they have started MCA recognized emergency medicine. Okay. Before that, it started in 2002. MD emergency medicine started in 2002, and only in Ramchandra, which is not MCA recognized. But recently, within 4-5 years, I think they started MCA recognized courses. Emergency medicine outside India and inside India, they are very demanding. Everyone needs the emergency people. Even in our own ER, we are a shortage of emergency doctors now. So though we are the first to start an emergency department in whole India. It's actually a good course, and it's one more I can tell is it's a end specialty as of now. So as days goes on, as the years goes on, I mean, there'll be super specialties for this course also. But at present, it's an end specialty and it's a growing field. So people still need emergency physician for every hospital. I feel every hospital should have an ER physician. And abroad also, it's quite a demanding field. I think there's a lot of scope in and outside India.
Okay, ma'am. Thank you for your time in this lovely session, ma'am. We're going to conclude.
Yeah. Thank you.
Thank you everyone for attending. If you have any more questions, you can post them in the WhatsApp groups and I will try to get them answered from ma'am if possible. Thank you so much.
Thank you. Bye.
Okay.
Bye.
We will be ending the session now.
Yeah. Okay. Bye. Bye. Bye, everyone.
Bye.